Hello and welcome to our new topic. Today's topic is on drugs pertaining to endocrine functions of hypothalamus and pituitary gland. Hypothalamic and pituitary hormones form the command center of the endocrine system. Every downstream gland, thyroid, adrenal, gonads, ultimately responds to signals generated here. The pharmacology of this system is therefore not just about individual hormones, but about understanding and correcting entire regulatory axes. So, let's start. The learning objectives are shown. Please take a look. The goal is to move beyond memorization and develop a clinical framework. Hormonal disorders are best approached by identifying whether there is excess, deficiency, or dysregulation at a particular level of the axis, and then selecting drugs that restore balance accordingly. This slide introduces the anatomical relationship between the hypothalamus and pituitary gland. The hypothalamus controls the anterior pituitary through the portal circulation, delivering, releasing, and inhibiting hormones directly. This anatomical connection is crucial because it allows precise regulation of endocrine function, and it also provides multiple pharmacological targets. This comprehensive table shows the hierarchical structure of endocrine control: hypothalamus, pituitary, and target organ, with feedback regulation. Every endocrine disorder can be understood as a disturbance at one of these levels. Pharmacologically, we can act at any point along this axis, which is why this framework will guide our entire discussion. Always think, where is the problem in the axis? In the next slide we will address all of them systematically. Growth hormone or somatotropin acts largely through insulin-like growth factor 1 or IGF-1, and plays a central role in growth and metabolism. Too little leads to dwarfism, while excess results in gigantism or acromegaly. These opposite clinical states illustrate how a single hormone can produce dramatically different outcomes depending on its level. Management depends on the direction of imbalance. Deficiency is corrected with recombinant growth hormone, whereas excess is controlled either by suppressing secretion with somatostatin analogs or by blocking receptor action with pegvisomant. This reflects a broader principle: target the hormone, its release, or its receptor. Prolactin is unusual because it is predominantly under inhibitory control by dopamine. Loss of inhibition, rather than increased stimulation, leads to hyperprolactinemia. This reverses the usual endocrine logic and has important therapeutic implications, as we would see next. Restoring dopaminergic inhibition becomes the cornerstone of treatment. Dopamine receptor agonists such as bromocriptine and cabergoline effectively suppress prolactin secretion and are particularly useful in prolactin-secreting tumors. Please recall that growth hormone and prolactin are both secreted by acidophil cells of anterior pituitary gland, while the other three, including ACTH, gonadotrophins and TSH, are produced by basophil cells. Next, we will start discussion on basophil cell hormones. The hypothalamic pituitary adrenal axis is tightly regulated by feedback. Cortisol suppresses both ACTH and CRH, and this feedback is exploited therapeutically. Exogenous corticosteroids mimic this effect, but prolonged use can suppress endogenous hormone production. Corticosteroids are widely used for their anti-inflammatory and immunosuppressive properties, yet their endocrine consequences must always be considered. Suppression of the axis can lead to adrenal insufficiency if therapy is withdrawn abruptly. Metyrapone is a targeted steroidogenesis inhibitor that primarily blocks the production of cortisol. In contrast, mitotane is an adrenolitic agent that causes physical destruction of adrenal tissue alongside inhibiting multiple enzymes. The overall action map is given on the next slide. This diagram shows the steps of adrenal steroid hormone synthesis with enzymes shown for each step. The drug targets are also shown. Take your time to assimilate this complex but important map. Gonadotrophins, LH and FSH, are anterior pituitary hormones which regulate gonadal function. Hypothalamus secretes gonadotrophin-releasing hormones in a stimulatory pulsatile manner, and this pattern is essential for normal reproductive function. The frequency and amplitude of pulses determine the release of LH and FSH, making this one of the most finely tuned endocrine systems. This slide highlights a very important pharmacological concept. Pulsatile GnRH stimulates the axis, while continuous administration suppresses it. This dual effect allows us to either stimulate fertility or suppress hormone-dependent conditions such as prostate or ovarian cancer. Briefly, the same hormone can either stimulate or suppress the axis, depending entirely on how it is given. GnRH-based therapy represents one of the most elegant examples of how physiology can be translated directly into pharmacological strategy. The key lies in understanding that the biological effect of GnRH depends entirely on its pattern of administration. When delivered in a pulsatile manner, it mimics normal hypothalamic function and stimulates the pituitary to release LH and FSH, thereby restoring reproductive function. This approach is particularly useful in certain forms of infertility where the axis is intact but underactive. In contrast, continuous administration produces the opposite effect. Instead of stimulation, it leads to downregulation of GnRH receptors in the pituitary, resulting in suppression of LH and FSH secretion. This creates a reversible hypogonadal state, which can be therapeutically exploited in several clinical conditions. For example, in endometriosis and uterine fibroids, suppression of estrogen production reduces disease activity. Similarly, in precocious puberty, continuous GnRH therapy helps delay premature sexual maturation by suppressing the axis. The same principle is applied in hormone-dependent malignancies. In prostate cancer, continuous GnRH analogs reduce testosterone levels, effectively producing a state similar to medical castration. In certain breast cancers, suppression of estrogen production can also be beneficial. GnRH antagonists provide an alternative approach by directly blocking GnRH receptors, leading to rapid suppression without the initial stimulatory flare seen with agonists. This makes them particularly useful in assisted reproductive techniques such as IVF, where controlled suppression of the axis is required to prevent premature ovulation. Ultimately, GnRH pharmacology is not just about drugs. It is about manipulating a physiological rhythm. By choosing between pulsatile stimulation and continuous suppression, we can either activate or silence the reproductive axis according to clinical need. Management of female infertility revolves around identifying the level at which the reproductive axis is failing and then restoring physiological signaling. When ovulation does not occur, the goal is to stimulate follicular development in a controlled manner. Clomiphene acts centrally by blocking estrogen receptors, removing negative feedback and increasing endogenous GnRH, LH, and FSH release. In contrast, gonadotropins such as HMG directly stimulate the ovaries, bypassing hypothalamic and pituitary control. GnRH analogs may be used either to stimulate or to carefully regulate the cycle, depending on the protocol. Dopamine agonists such as bromocriptine are particularly useful when infertility is due to hyperprolactinemia, where suppression of prolactin restores normal ovulatory cycles. The key principle is to match the drug to the level of dysfunction within the axis. Conditions such as endometriosis are driven by estrogen-dependent tissue proliferation. The therapeutic goal here is not stimulation, but suppression of the reproductive axis to reduce estrogen levels. Combined oral contraceptives and progestins create a hormonal environment that limits endometrial growth, while GnRH analogs produce a more profound suppression by down-regulating the pituitary. Danazol acts differently by creating a hypestrogenic, androgenic environment that inhibits endometrial tissue. These strategies illustrate how manipulating the same axis can either promote fertility or suppress pathological tissue growth depending on clinical need. In male infertility, the focus shifts to restoring spermatogenesis, which depends on coordinated LH and FSH signaling. Gonadotropins such as HCG mimic LH and stimulate testosterone production, while FSH promotes sperm development. In hypogonadotropic states, this combination can effectively restore fertility. The estrogen receptor blocker clomiphene tricks the brain. Blocking estrogen receptors boosts testosterone by interrupting a negative feedback loop that usually tells the hypothalamus to stop producing it. In men, a portion of testosterone naturally converts into estrogen. The hypothalamus and pituitary gland monitors these estrogen levels to gauge how much testosterone is in the body. Thus, clomiphene helps increase gonadotropin release, thereby increasing testosterone production as well as spermatogenesis. Erectile dysfunction, although partly hormonal, is more commonly treated through vascular mechanisms. Agents like sildenafil enhance nitric oxide-mediated vasodilation, improving penile blood flow. This highlights an important distinction. Not all reproductive disorders are purely endocrine, and treatment must be tailored to the dominant mechanism. Suppression of the reproductive axis has powerful clinical applications. In precocious puberty, early activation of the axis is halted by continuous GnRH analogs, allowing normal timing of development and indirectly preventing early epiphyseal closure. In hormone-dependent cancers such as prostate and certain breast cancers, reducing sex hormone levels slows tumor progression. In assisted reproductive techniques, such as in vitro fertilization, a controlled suppression prevents premature ovulation, allowing precise timing of fertilization. These diverse uses are all based on the same principle: continuous GnRH exposure leads to functional shutdown of the axis. Energy balance is tightly regulated by hypothalamic centers influenced by leptin and ghrelin. Leptin, produced by adipose tissue, signals energy sufficiency and suppresses appetite, whereas ghrelin, produced in the stomach, stimulates hunger. In obesity, leptin resistance disrupts this regulatory system, leading to persistent appetite despite adequate energy stores. Although current pharmacological therapies do not directly target leptin or ghrelin, they act on the same hypothalamic pathways. This makes these hormones highly relevant, as they define the physiological framework within which modern anti-obesity drugs operate and represent important targets for future therapies. Now let's start some discussion about posterior pituitary hormones oxytocin and antidiuretic hormone. Oxytocin plays a central role in reproductive physiology, particularly in childbirth and lactation. Near term, the uterus becomes highly sensitive to oxytocin, allowing it to stimulate coordinated contractions during labor. Clinically, it is used to induce or augment labor and to control postpartum hemorrhage by promoting uterine contraction. One should remember that oxytocin use demands a careful alignment with progression of childbirth, because a premature administration can cause dystocia rather than facilitate childbirth. Its effects on milk ejection further highlight its role in maternal physiology. Oxytocin also plays an important physiological role in sexual intercourse and emotional bonding. At higher doses, oxytocin can also produce vasodilation and mild antidiuretic effects similar to its cousin ADH because both share structural similarities, which must be considered during administration. Antidiuretic hormone or vasopressin regulates water balance through V2 receptors in the kidney and vascular tone through V1 receptors. Desmopressin, a selective V2 agonist, is used in central diabetes insipidus to restore water reabsorption. It also has additional applications, such as increasing factor VIII and von Willebrand factor levels. In contrast, conditions of excess ADH, such as SIADH, require antagonism of this pathway. Drugs like tolvaptan and conivaptan block V2 receptors, promoting water excretion and correcting hyponatremia. The distinction between deficiency and excess once again determines whether we replace or inhibit the hormone. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!